All right. Hey, everyone. My name is Alvin Sun, and I'm the podcast coordinator for the Surgery Interest Group. Welcome to our podcast series where we invite guests to share their expertise and experiences in the field of surgery. Today, I'm excited to introduce our guest, Dr. Randy Lehman, who has generously taken the time to join us to share his incredible journey, answer some questions you guys submitted. He went to medical school at the University of Cincinnati College of Medicine, completed his general surgery residency in the rural track at Mayo Clinic in Rochester, Minnesota. Now he's attending affiliated with multiple community hospitals and also has established his own practice where he does a broad range of surgical procedures back in his hometown in Rensselaer, Indiana, which is awesome. I've had the privilege of working alongside him actually as a scrub tech all the way back during his residency years. So it's been inspiring to follow his growth and success. He's definitely a surgeon who I want to emulate in my own career. So without further ado, let's welcome Dr. Lehman to the podcast.
Thanks, Alvin, for that very generous introduction. I appreciate the opportunity to come talk with you guys.
Just to start us off, are you able to give us just a brief bird's eye view rundown from medical school to where you are now, kind of like what that has been like for you so far?
Yeah. So there's every human being just has a story, and I feel very strongly that I've been sort of guided through my life, and there's no way I would have ended up where I currently am if that wasn't the case. Um, but I could go too far back and tell you, but one thing I would like to say, just to have a general concept of what's going on in your particular life, is all the times when I've had what would maybe look like my biggest failures. Those were the times when I was actually being set up for something much better. And so, for example, I didn't plan when I was in high school to do all of this. I didn't even really want to go to college. I just kind of wanted to start a business for myself or something. I knew I wanted to live kind of in back home where I was raised. Anyway, I got a scholarship to go to college. I ended up deciding to go to Purdue because my buddy was going there, and then I decided to go to um, pharmacy school just based on a couple conversations that I had with people at the right time. And I hated it. I had 4 semesters of declining GPA in pre-pharmacy, and then I didn't get into pharmacy school. And 100 people get into pharmacy school, and 1,000 start in pre-pharmacy every year at Purdue. They're top three pharmacy school in the nation. And so I had witnessed a lot of my classmates switching to easier majors. And mostly I looked at my credit. I mean, had declining GPA, but I still had, whatever, a decent, it was like in the mid threes. And I had all these science classes, and I knew of a couple friends that had gone to medical school. And so I just got a fire kind of lit inside of me, and I was like, yeah, forget this. I'm going to go to medical school instead. And then I thought I was going to do emergency medicine, and my advisors told me, no, you don't do that. Look at your, record. You're not going to get in. And I knew that I just wasn't trying really. And so then I switched, got straight A's, actually got into pharmacy school the next year, and then went ahead and and went to medical school anyway. Um, but that was it was a little bit of a gut check, and it's how you respond to that when you get knocked down. And then I had other situations like that throughout my life, and most of the time it's the doors are opening and the way is being paved for the next big step forward in your life, especially if you don't crumble under that pressure. So, and look for opportunities. And then also be true to yourself is the other thing. So I wanted to go back home to Rensselaer, Indiana, and try to, you're not perfect. Everybody's the hero of their own story, right? But you're not really a hero. You're just another guy. But you want to try to hang on to those altruistic motives that you talked about in your medical school interviews. And there, it, it, it might seem competitive, even cutthroat, at different stages through your training. But on the back end of all that is real life again. And so at that point, you don't win in real life by being super competitive. You win by being collaborative, and also by focusing on core values that never waver and don't go away. So, for example, I knew I wanted to go back to Rensselaer, Indiana, and my goal was to provide high quality care close to home. That was my whole mission. And I knew and believed that if I did that, then I would help my community. Really, what I wanted to do is help my community even more than the medical piece. And even when I was not going to go to college in the first place, I wanted to help my community and make the place where I grew up better. And so if you can focus on that, then all of a sudden the decisions that you have to make that are complicated, what surgery should I offer in this town? Um, how should I treat this coworker? Uh, how should I treat this complication? Where should I go get training? Those questions become much easier when you've got these core fundamentals that even though the world's going to change dramatically over the next 5, 10, 20 years, those core concepts of I want to make my place where I live better, followed by I'm going to do that through being a surgeon and providing quality care close to home. That's going to be my mission. Then those things will always be there to guide you. So then I had to make some decisions. And as I was going through medical school, so I distinctly remember being in Cincinnati Children's Hospital and making a pros and cons list of what I wanted to do residency wise. And I found I wish I had the link to share to you guys, but I found something online that was like a test for what specialty you should do. You put in all of your character traits. I remember taking the test twice to kind of try and increase its validity, and it wasn't one of those cartoon things, which are pretty funny and actually accurate, but it was a serious one. And what it told me was that it said, you really like to do procedures and you like to do episodic care. And you don't like to manage the same patient for a lifetime, but you don't like to do like 6-hour operations either. And let's see, what else did it tell me? That's basically it. And then it recommended you should do ENT, OBGYN, urology. Those were kind of the recommended things that were right at the top. And then general surgery was in there, maybe somewhere in the 6 to 10 range. Your stuff like cardiothoracic surgery with the real long operations, big wax, back-breaking stuff, fell a little bit lower. And rheumatology was last. So rheumatology is classic because it's managing a problem for the life of the patient and not fixing it, just managing it, which is like the opposite of the concept of surgery. And at that time, I knew I wanted to go back home. And so that was my underlying thing. And I made a pros and cons list, which was for 3 specialties, really, which was what do they need back home? Family medicine, emergency medicine, and general surgery. And I just remember imagining being an ER doctor and calling the surgeon and letting them know that I diagnosed appendicitis and then the surgeon coming in to fix the problem. And I wrote as a con, all the cons under surgery were like, it's a longer, harder residency. That was mostly it. Maybe a little bit of lifestyle, like call type stuff. I don't know, because there's shift work, if you work in the ER, but then I wrote as a con under emergency medicine, will not be a surgeon. And that's when I knew. I was like, okay, suck it up, go through. And then right after that, I discovered, so I committed to do surgery, but then I talked to the chair of our department and I told him I wanted to be a rural surgeon. And I found out that there's all of this like undercurrent about rural surgery. The American College of Surgeons is really big on it, and then certain residency programs have developed training tracks in rural surgery. Well, what is that? Um, it's it's a highly variable thing, right? And the training tracks are highly variable, and the jobs on the back end are highly variable, and it's sort of what you want, but you can really get what you want, especially if you start as like a third year medical student. Go find the right training track, and then from day one, if you can imagine yourself, if you know where you want to go and you can imagine yourself there, then you can get the appropriate training and then also develop the resources while you're going through training so that you can call people and have a network of people to ask when you're kind of out there on your own, because professional isolation is a big problem, and mentorship is the one of the biggest solutions to that. So getting back to what it is, it's basically a surgeon that's in a rural place who usually did general surgery training, but they may do not quite the full spectrum of general surgery because it's not appropriate to do esophagectomies and Whipples and liver resections in a critical access hospital. But they may add some subspecialty things from ortho, urology, OBGYN, especially plastics, and ENT. And so for me in my practice now, the funny thing is you don't know when you're going through training what the true need and incidence is for all these things. And when you're going on a rotation with an ENT, for example, as a trainee, you might think that parotids are just as common as thyroids, are just as common as tympanostomy tubes, are just as common as nasal foreign bodies. And then you get out and 4 years goes by and you get 0 referrals. And then you're like, okay, well, I'm not going to do that because the need is not there. And so I don't need to do that. But right now, I would say it depends where you're at geographically. But the biggest need that's outside of just true general surgery is colonoscopy and EGD and C-sections. If you go by the 80-20 rule, 80% of your results come from 20% of your efforts. Boom, that's it. If you were a general surgery that knew how to do those two things, you would be able to meet the needs of like 90% of these rural communities. The other things that I do, so then I'm just going on. Do you want me to continue?
Yeah, go ahead.
How?
Yeah, yeah, go
Okay. Because then what happened when my chair found out I wanted to be a rural surgeon, he introduced me to a mentor who was in Central Kentucky. I went down and did a rotation as a 4, and then I discovered that there are these specific training tracks for rural surgery. And then I applied to a bunch of them, but I was a little bit late to the game because I was finding out about this like I'd already kind of completed my application and everything. But I got several interviews, and then I ended up getting I interviewed at 16 places, but 3 of them had rural surgery tracks, and I ranked them 1, 2, 3. And then I matched into the one at Mayo Clinic, which was actually my number 2. But it all works out, and you should totally trust the match, because if you match at a place, the nice thing is that they wanted you to. So now you match where you were supposed to. So my track had dedicated rotations as a 4th-year resident in ortho, urology, ENT, plastics, and OBGYN. And so what does that basically, and the nice thing about it was I was a 4. So I was I don't want those then. Did you freeze? Did I freeze?
Somebody for that wasn't sure.
Okay.
That's good
So
knowledge.
anyway, I'll carry on. So as a 4, you want to do those rotations as a 4, or I mean as a senior resident.
Mhm.
And then you want to do them at a place where there's no other residents.
Yeah.
And ideally a high volume place. So it's not about like getting a rotation at a tiny hospital in your training. That is not, that might be an immersion and an exposure for somebody. And you could do a block like that. but it's really about getting cross-trained in other subspecialties so you can go to a place and kind of be the surgical gatekeeper for your community if you want to do rural surgery. And you want to be in a high volume place with like as much of your training as possible. And ideally with not too many competing residents. It's good to be in an academic place where there are other trainees and then you can bounce you can learn from each other and everything. But you just want the volume to be there, the case volume to be there. And so as you're looking for training programs, I remember I interviewed at community programs and academic programs, and you really your training is what you make of it. And more than probably almost anything, well, everything in life is like that. Your marriage is like that. Your relationships with your kids are like that. Your health is like that. But definitely surgical training is like that. So I interviewed at a community place where the residents were bragging to me about doing, uh, 1,600 cases, and then they had to stop logging their cases because they had done so many that the whoever the board is that's over the residency programs would have come in and gotten their whole program in trouble because it's not possible for them to be doing that many cases and still be meeting duty hours and stuff like that.
Mhm.
But then I asked them about what kind of cases they were. And I said, so how many Whipples have you done? How many liver sections have you done? Well, we always get our numbers for that. So you have to have 5 liver and 5 pancreas to graduate, right?
Mhm.
And so they said, but normally, we'll have 2 or 3 residents scrub into those cases, and then we'll all log the case.
So,
Okay, so the truth comes out.
yeah.
They did 1,600 tiny hernias and gallbladders, basically.
Mhm.
And they just sat there and they cranked out general surgery in a place where there were subspecialists. And when they got out, I'm sure they were very good at doing tiny hernias and gallbladders. Um, but they really didn't know their way around the pancreas at all. And they got their minimums for all the complex things. So then I went to Mayo, for example. Mayo had an average of 950 cases per graduating resident. But then they would throw up their numbers and it would be like 15 pancreas and 15 liver. And then I'm talking to them and they're telling me about, well, we're on a preceptorship model when we do hepatobiliary surgery, and we we go with one-on-one surgeon, and normally it's just us and them in the case.
Mhm.
And that was how it actually turned out to be. But it's more than that. Like then my track, I got to go out to Mankato, La Crosse, um, Eau Claire, um, Owatonna, and these other hospitals where I felt like I got the best of both worlds. Because when I went to those locations, they were doing high volume gallbladders and tiny hernias.
Mhm.
And then I got to and they did other stuff too. I mean, they still did thyroids and colon resections and carotids and stuff, even at some of the places. But um, it was just me. And if I wanted to do 5 to 7 cases a day, I could. And if I didn't, I wouldn't have had to. But I wanted to, and I put in the time. And so then I just got better and better. And by the time I finished at Mayo, the last 3 months I was off because of it was 2020. And I was supposed to come out and do like probably another 150 cases at La Crosse during that time. But instead, I did almost nothing. And so I still finished with 1,600 major cases. I had 19 liver, 19 pancreas. I blew all my foregut, my stomach numbers out of the water. I did like 50. I did tons of hiatal hernias, and it all just kind of fed on itself because my intern year well, even when I was in medical school, you know, I spent extra time and learned as much as I could. Um, and then as an intern, I spent extra time and stayed and practiced my technical skills so that when I showed up, especially if you show up after hours, or if you show up when you're not supposed to be there, you get more opportunities because the staff is proud of you. And so then you get better. And then the next time you show up, they have more confidence in you and you get more and more autonomy. And so by the time I was done, it was middle of the night and I had um, a sigmoid, an incarcerated left inguinal hernia going under a rigid fem bypass graft with a cancer inside the sigmoid colon, which was incarcerated out there. And it was 3 o'clock in the morning and I did the case all by myself.
Wow.
And that was my training by the time I was done. I'm not saying that you're going to get that everywhere, but those are the things that you want to be thinking about as you guys are all applying for your programs. How do I find out the actual truth about when I get done? And then you can also ask the residents, you know, are you comfortable going out on your own? And what you'll find is like at Mayo, there were people that were totally not comfortable going out on their own, and they did fellowships and got comfortable doing their niche. And no, I mean, I wouldn't even say I was like comfortable, right? Everybody's going to be nervous going out on their own, even when you feel like you had really good training. But you do you have anybody from your program that is going straight out to practice? That's a big question that you want to ask.
Yeah.
So I don't know, that gets you kind of caught up to my program and then my training. And what else did you want to talk about?
Yeah, that was like actually kind of the next question. So you felt like your residency program prepared you enough for rural practice, and since it seems like you need a pretty big skill set for rural practice, or depend since doing like a lot of procedures that are typically done by specialists, or like hysterectomy, like you said, and thyroids, maybe like some thoracic surgery as well.
Yeah. So I I could have, again, I'll reiterate, I could have hid in my residency program and not been prepared. But I
Mhm.
kind of like leaned into it and made myself uncomfortable all throughout training as much as I possibly could, which made my comfort level a little bit higher by the time I got out.
Mhm.
But still, you know, you're going to be uncomfortable, but it's better to be uncomfortable in residency when you feel like you've got a lot to lose, but you don't. When it's actually a safe time to be uncomfortable and to fail
Mhm.
than it is to do that when it's just the one patient relying on you and you have nobody else, no safety net. So, um, let, let me talk about my practice then a little bit, because even though I did those higher level cases, the esophagectomies, the Whipples, the liver sections, the lobectomies, I knew none of those cases would I do in a critical access setting. And there's also a difference between a surgeon who practices in Sioux Falls, South Dakota, or who practices in La Crosse, Wisconsin, or Owatonna, Minnesota, or me in Rensselaer, Indiana. So a critical access hospital is a government designation for a hospital that's got to be 25 beds or less, 30 miles or greater away from any other hospital, and it has to offer 24/7 ER and then certain other things. Surgery is not actually one of those things, but surgeons and hospitals are very symbiotic. It's very hard for a surgeon to exist without a hospital. It's also hard for a hospital to exist without having a robust surgery department. And so rural surgery is a key important part to keeping these critical access hospitals open. And the big chains right now are fighting against the rural hospitals. They're generally, I would say, generally buying them up, setting the referral systems up so that the patients get used to coming to their bigger site, and then shutting down services. So be very wary of the chain coming in and buying your hospital. Every chain has done this. IU's done that in Indiana. Franciscan has done it in Indiana. That's what I'm fighting against with my hometown hospital where I was born. Mayo Clinic did it with Albert Lee. They put up a hospital, and Bobby got stout, administrator extraordinaire, OBGYN turned administrator, was quoted as saying, I would drive 26 miles for groceries. And it was 26 miles away from Austin. And they shut down the Albert Lee Hospital, which was $10 million hospital built by the community, mostly aging people, 10,000 people that live on the lake. And they don't want to go to Austin. They built that hospital like for a reason. They want the hospital in their town. And the people that are making the decisions do not understand that. That's the problem with rural, the rural hospitals and the closures. And then it's a very complicated issue too, because you got to have doctors that want to work there, and you got to have nursing staff that's of a certain quality to be able to work there. Your resources are stretched thin. Reimbursements are going down for hospitals as well as for physicians, and the new policies that are being rolled out, like Affordable Care Act. One of the main policy writers for Affordable Care Act was quoted as saying, we're intending for this to increase vertical integration within healthcare, which means that small hospitals are going to become part of a bigger chain, and there won't be that personalized, individualized and local service for people. They're going to have to, doctors are going to have to become employed. That's what one part of vertical integration. And then the doctors become the cogs in the wheel of the machine, right? And so I don't want to get too far down the rabbit hole of all this, but these are some of the challenges you're up against in rural surgery that you're not even thinking about. Right now, we're trying to say, well, how can I be a competent general surgeon who also does hysterectomy? How can I learn to do that? You know, and then the problem is you do that and you come out on the back end, and then you have to potentially fight against the hospital to say, no, I did get trained to do this, and then get your privileges. So think about that as you go through your 5-year training track, because on the back end, you're going to have to justify to some administrator at that hospital who has no idea whether you should or shouldn't be able to do this thing that's out. They have a list called core competencies for general surgery, and they're going to sign that thing, and you're going to say, you're going to bring a paper from your residency program, and they're going to say, yes, you're okay to do this. But then there will be things, if you're trying to be a rural surgeon, like when I came out, I was asked by the hospital to manage kidney stones. And I spent a bunch of time at the end of training going with the urology guys, figuring out a little bit more in addition to what I'd already done to manage kidney stones. And then I got set up, and I set up myself to go down to IU, which is our big referring place in Indiana. Went with the main guy that does kidney stones down there, spent 3 days with him, worked on the model, watched him do, 20 cases, whatever. And then he agreed to review my cases like retrospectively and not send him a disc. And I did all this stuff. And then basically the hospital said, no, we're not going to make a way forward because we have nobody locally that does this. So we can't say that you're okay to do this. It was like the most, like, I just felt like my brain was exploding. To be like asked to do it and then told that no, we're not going to provide a way. So that's what you're going to be up against. So as you're leaving, if there's things that you specifically want to have in your practice, make sure that your program director is prepared to back you up and potentially have a conversation or send a letter to the place. And ideally, if they would even have a way to proctor you afterwards, like the hospital might be under certain obligations to have your first so many cases proctored. And if there's nobody there to do it, if your program could like accept a packet with like the H&P and the op report, maybe a disc or something, and they could remotely proctor you afterwards, that would be fine too. So just different things that you want to start thinking about when you're a 3, 4, 5 resident. And so let's talk about what I actually do in my practice now. And so my most, I mean, for as far as bread and butter general surgery, I do gallbladders and hernias and appendix, and then I do belly stuff such as bowel obstruction, um, colon cancer, breast cancer. I theoretically do thyroids or did thyroids. I have not had that many referred to me so far, and and every time I do them, I don't have a nerve monitor, and I don't have intraoperative PTH monitoring for parathyroids, so that like eliminates a few other cases. And the volumes have been so low that I just made a decision recently that I'm not going to do them until I get a partner. And if my partner wants to kind of like take it on, I'll back him up. But it was kind of I didn't really look forward to those days, and so I just decided forget it. And you'll figure out those things for you, but come out prepared to do all of it and then see, how things go. But then I have been doing a ton of hiatal hernias, um, and that I just think I don't know how many thyroids I ended up doing in training, but I think I was more autonomous with the hiatal hernias by the time I was done with training than I was with the thyroids. That might have something to do with it. Um, And so I'll do those and then I do a lot of skin cancer and then that's and lumps and bumps everywhere and wound management, things like that. Um that then for specialties that normally come out of general surgery, like let's think vascular. So I don't do any arterial work basically at all. You have to have all the balloons, all the wires, all the stents, all the equipment, the graphs. And one thing that I thought about a lot was, what about the ruptured AAA?
Mhm.
Um, and when I did my vascular rotation, it's like, okay, how am I going to handle this when I'm the only person?
Yeah.
And now what I realize, it depends where you live. So if you live in the really in the West, where it's like, 4 hours by fixed wing airplane to get you somewhere,
Mhm.
that might be a little different. And I think that though that's why I said like somebody that's in Sioux Falls, that's a rural surgeon, but that person is potentially doing vascular and more thoracic stuff, and especially the emergencies, and they're really doing the trauma, but they have an OBGYN in their hospital.
Mhm.
And they have ortho and they have urology and ENT. So they have all the specialties. And so they're doing a very broad spectrum of the higher level. They're cutting into the higher level of general surgery. Whereas what I'm doing is I'm eliminating the higher level of general surgery. And I'm doing some of the very bread and butter, easy stuff that almost always goes well from the subspecialties because we literally don't have a urologist. We do not have an OBGYN that even comes to my hospital. We don't have an ENT that comes to my hospital. And so people have to travel out of town for those basic things. So I got a fishbone in the vallecula that they called me about a week ago, and I did a DL and took it out. And um, they'll call me about the nosebleeds and the foreign bodies in the ears and the nose. Um, and they would call me about a testicular torsion, I would say. Um, I do vasectomies. I do manage like hydroceles. I just got a phone call for scrotal cellulitis. Um, from a OBGYN perspective, it's basically benign GYN stuff that I manage, but there's a doc that's in the hospital I'm at who has been managing most of it. And so for example, Novasure ablation, the DNCs, tubal ligation, which I do laparoscopic bilateral salpingectomy. Last week I had a very interesting one. It was a um pyosalpinx, and we tried to manage medically initially, but she had peritonitis and was just like very, very tender, and her tube was really dilated with a big, huge pocket of pus, and she was in her late 40s, and so we ended up doing a salpingo oophorectomy on her. and her ovary was abnormal as well. And so, and then she got better right away. So some of that stuff, and I called, my couple friends that are OBGYN. So that's how you find your way around it. Like, this is what I'm reading, this is what I think I should do. Do you agree? Yes, I agree. Okay. Well, then I know I can safely get the operation done. It's the decision making that's the hard part. And then from an ortho perspective, I do a little bit less than I thought I might. I thought I might pin a hip in an old lady that falls out of bed or something that really doesn't want to travel out, and maybe but I don't do that really at all. I do carpal tunnel, trigger finger. Um, that's about it. And then I guess it depends which specialty you put amputations under, but you know, basically I do podiatry, vascular, ortho, and it all falls in general surgery, but the infected toes. And we'll go back to vascular. So I don't do the arterial, but I do varicose veins, which is super simple and easy if you can get the training to do it. Um, and ports and lines and AV fistulas. So you can still do some vascular work. And then there's overlap there there's a lot of people with dead parts of their extremities walking around more than you think. Processes, developing a relationship with like a arterial vascular surgeon somewhere else, and then work them up, get them to where they need to go, clean up their wounds, and sometimes you get pretty dramatic results. From a plastics perspective, like when I do these skin cancers or manage big wounds, I'll do skin grafts. That includes split thickness skin graft, full thickness skin graft, rotational flaps. Um, you know, from from a colorectal perspective, the pilonidal, I do a keratosis flap, pull a tissue over off midline closure. Um, the all the perianal stuff comes to you as billed as hemorrhoids, but it's not. Sometimes it's prolapse, sometimes it's hemorrhoids, sometimes it's fistula, sometimes it's fissure. You just have to figure out what it is and manage it. That'll keep you busy. Um, that kind of gives you an idea, right? So I never say no right out the gate. Do you do this? I say, well, tell me more. Let me hear about this. And then I use my knowledge, my skills, my experience, as well as look things up and determine if I think I can help that person and keep the care local, for all the underlying altruistic reasons that I think that it's the right thing because it's good for the community and it keeps our jobs in our community, it keeps revenue in our community. If I'm there and I say yes to things, then it keeps our hospital lights on and it keeps our doors open, and then businesses that are coming into our community know that there's a hospital there and they might come. There's all these downstream effects that you're not even really sure how it's going to end up. And so now that's how I make decisions on what's in and out of my practice. And now it's like established. I'm 4 years out of residency. But when you first come out, you want to just come trying to be prepared to do as much as you can, and then it'll become clear what's really needed. You know.
Yeah, do you find it difficult to like, maintain all the knowledge and skills since it's such a broad um, field?
Yeah. Being busy is the antidote for that.
Yeah.
And so when I first came out, I actually the hospital that I was born at, where I wanted to go practice. First off, I didn't know if I kind of wanted to be independent, but I didn't really know what that was all about. And I had student loans. And then that hospital was bought out by a chain. And so they didn't really have a job, and they didn't even really want, I think they honestly don't even really want surgery to be done there. Some of the ways that they act, but um, they didn't want to commit to a full-time surgeon. I knew I could get my loans paid off by an employer, and especially if I signed a contract early. And so I was talking to that hospital right when I was going to residency, and I said, look, I'm coming there. Is there something? Can we sign a contract? Can we get something set up? And they said, uh, Well, we would love to talk to you about that. You can talk to our physician recruitment team. They're in Indianapolis, just 2 hours away. And, here's their number. And I call, and of course they didn't answer right away anyway. And I was like, okay, you guys clearly do not understand this. And it turns out that I was correct. That's their only critical access hospital that they have as part of that chain. They don't understand rural medicine. And so I end up going to residency and getting started, and um kind of forgot about it until I went on a mission to Honduras, which I have done a lot of that. Then as I became more medical, my trips became more medical, and then I became more surgical. My trips became more surgical. But anyway, with my mentor that I mentioned earlier, Eugene Shively from Central Kentucky, we went down to Honduras. That was the second time I went with him. I went as a fourth year medical student, and then as an intern. He came back and he talked to his CEO, and they had an educational stipend, and he said, we got to give this to Randy. And so then I went down there and interviewed actually at Kentucky, almost took that job, figured I should probably look around a little bit more. And so I talked to Merritt Hawkins, which is a physician recruiting company. They found me a place in Missouri, which was near where my aunt lived. I almost took that job. Both places were going to give me loan repayment. I was going to sign as a second year resident at this point. And then my wife got pregnant, and we decided to kind of wait until my kid was born. We didn't know, found out it was a daughter when she was born. And when that happened, it became clear that we wanted to get back closer to home sooner. And so I went on Google Maps, literally, to Rensselaer, which is my hometown, and I zoomed out. And there's 4 hospitals that are kind of equidistant around there, kind of looks like a 5 dice. And I called all those hospitals, and I said, hey, this is my deal. I'm interested in rural surgery. Do you have a job? And the places that were part of a chain all said, call us back when you're at 4 or 5, which was 3 of them. And the places that were independent said, absolutely, we got to get you here. When can you interview? And so I went to both of those places and interviewed, and one was in Illinois and one was in Indiana. I kind of wanted to be in Indiana, and they offered me sort of everything that was in my other 2 contracts, and I ended up signing in December of my second year of residency, a contract where I started getting monthly payments, which was structured as a loan. But I could have used that money for anything I wanted to, but I had the discipline to pay my loans off with them. And then by the time I left residency, I was debt free, except for the time that I owed them, which is 4 years. But then of course, during that time, I had a good paying job with a high salary. And so then I went there, and I tell you all that backstory to answer your question, which is, how do you stay up on all of this stuff when there seems like there's so much? That county has 12,000 people. This is something else to be aware of that I was not aware of, is the demographic and what's the need for a general surgeon. So have you ever thought of that? How surgeon per population?
I'm not really sure what the number would be. It's like a clear-cut number for that.
So nationally, there's 1 surgeon per 19,000 people. And most people agree that we don't have enough surgeons, but there's one paper that I read that said the actual correct number would be 1 per 14,000
Oh.
population. So I went to a county with 12,000, and they had 2 other full-time surgeons there. So we were actually way overstaffed. Now, I can kind of get around that because I do scopes and I do this broad spectrum practice. So there's some things that you can be busy because you do more than just traditional general surgery. But I was not busy when I first started, and at first it was like, okay, it's cool. I can like relax and spend a couple months with my family as my practice is growing. But then I got stressed out about it. And I was like, I need to be busy or else I'm never going to keep my skills up. And then I had like extra vacation time because I wasn't using vacation. My whole life was a vacation, basically, right when I started out. And I got an email from a locums company, and I had extra vacation time, and so you get all kinds of emails like that. You just delete, 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 delete. But one of them was for Prairie du Chien, Wisconsin, which is a place that I had been in residency, not as a surgeon, but just I knew where it was. It's a beautiful place on the Mississippi River. And so I was like, hey, I could check that out. So then I ended up going up there my first summer, a year out of training, and spending some time up there, do a handful of cases, um, but then kind of get a paid vacation. And I always take my family with me, and as a little bit of a life hack. And then my practice started to pick up a little bit back home because I was talking to the doctors in my hometown, telling them I'm gonna come there eventually. I'm just practicing the next county over right now, but I'll be there. So if you need me ever, just call. I've got a call team over here. You don't have to worry about sending them to Lafayette or whatever. And so the practice was growing. And then several things happened at once, but mainly there was a surgeon that I was starting to become friends with at my hometown hospital in anticipation of going over there. And he ended up having a bad stroke. And he had actually signed a paper that said he would look after my patients if I dropped dead or whatever. And, like we were starting to become very collegial. And then he completely last time I called him, he didn't make any sense. He's still alive, but I don't think he's going to practice anymore. Anyway, he was working 3.5 days a week there. My hometown county demographically is 30,000 people. And there's another county next to it, which is 14,000, that has no hospital. So you're talking at least, and then there's counties around it too. I think the catchment area could be as big as 100,000 people, but it's at least 50. And there they had a group of surgeons that was coming 2 days a week. And then they had this guy who was coming 3.5 days a week. And then he went, he wasn't there. And so then all of a sudden it became an emergency and they needed help. And you can see the difference in demographics. 3 full-time surgeons for 14,000 people versus basically a 0.4 for 50,000. And so then I was just open the whole way through with all of my intentions and my motives, and with my administration at the place where I was employed, and they allowed me to go on a limited part-time basis over there and start an independent practice, which I did. And then a building kind of fell in my lap. I bought a building. I built the whole practice that I thought I needed. I hired a nurse practitioner, I hired a bunch of people, built a bunch of overhead. And before you know it, my overhead was $600,000 a year. And my income for me and my nurse practitioner was 300. And I never made any money doing that stupid private practice attempt. And I ran the numbers, and it was partly because I was part-time over there. But if I quit my regular job and I went over there, I would maybe make money, but it would be about a quarter of what I made at my employed job because the overhead just kills you. So that was a big learning experience for me that you guys can learn from me. That basically, what people had told me, which is that private practice is not viable right now in 2024 in the United States. I now believe that to be true. But, well, let me take that back. The way I was doing it, brick and mortar traditional way it's not viable. But then that is the second great example of life looks like everything's crumbling down, and it was really hard. It's really a gut check to have like a failing business. Patients are very happy. The primary care docs are very happy. My employees were even happy. Everyone was happy except for to the business to keep the doors open. So, but what that allowed me then to do, and everything was kind of uh I the next door neighbor was the hospital's urgent care, and they were talking about adding on to their building, and they didn't have enough space, and my building is huge, and I was like, I don't need this space. My business is not working. I was trying to get a contract set up with the hospital where I could offload the overhead basically to them and just come in as a contracted surgeon for them. They were not really responding. It was taking forever, like months and months, if not, we hadn't been working on it for a year, maybe. I had called the person that was in charge of the urgent care several times, voicemail, couldn't get through. And I was ready to, like, the problem is my dad had quit his job to help me get my business off the ground. I had a nurse practitioner who was amazing, and I just wanted to keep her, and she was from Rensselaer, but I didn't want to lose traction on what I was doing, but I was ready to shut it down. And this is like a big jump. How did you get from the guy having the stroke you just started into this? The timeline on that was about 18 months of just like hard pushing that forward. And this is about uh 6 months ago, I guess at this point, maybe a year ago. And my wife and I was a very stressful time, and I distinctly remember this time where we came home from church on a Sunday afternoon, and we don't normally do this necessarily, but we said a prayer out loud while we were driving and basically just gave it up. And I was like, this is failing, and I think I'm just going to shut it all down. But if there's something like, praying to God, if there's something that you want to do with this, then feel free to take over. And the next day, I got a call from the urgent care, who I'd been calling for like 6 weeks. And they're like, yeah, sounds exactly what we need. And then within that week, they'd sent a team of like 8 guys out and architects and everything looking at my building. That next week, I got like the draft that I was waiting for a very long time for my contract at the hospital kind of came through. And it all just, I mean, it wasn't me, is how I feel about it. Everything just fell into place.
Yeah.
And I feel like I had to be humbled to the point of where that it was clear that it wasn't me that was doing all this, and then just kind of get out of the way and let things happen. And that's happened so many times in my life, I can't even tell you. And so now my model is I still have my employed job, and now I'm contracted at my hometown hospital, and they have set it up in a way where I just go into the hospital and use their nurses, their computer system, their supplies and equipment, and all their overhead. And now they're actually going to take over billing for me as well. And I just get paid a daily rate for showing up, and I've got a productivity incentive on top of that. So I can't lose when I show up. And they never would have given me a nurse practitioner if we started with that kind of model. But since I proved her value by all that, the nurse practitioners rolled into it. So she's got a daily rate. She still works for me. My business is called Liberty Clinic. I actually got my first check from Liberty Clinic. Now that I've started this new model, I haven't wrote since we started this way. I haven't wrote a single check to my business, and we make money when the nurse practitioner is working. We make money when I'm working. The hospital makes money when we're working. And it's all viable. And most, so that we can actually do the mission that we want to do, because you can only pay to do it so long, and it eventually needs to stand on its own 2 legs. Then after that, one of the doctors in my hometown started going to another critical access hospital to the side, like to the next county adjacent to us. And he said, called me and said, "Hey, have you checked out this county, because it seems like they have nobody for general surgery." And I called the hospital and they're like, "We're dying. Please, what can you do?" And I said, "Well," they said, "you could come rent some space from us and bring your own staff and see your own patients and bill your own and be an independent surgeon here." And I'm like, "No." I tried it, doesn't work. But this is what I've done over here. It's a contracted type of a relationship, and you can take care of all the overhead and the billing and the business side of it, and I'll just come in and be your contract employee. But I feel more free doing that as a contracted employee. That's not the right word. Independent contractor. You're not supposed to use the word employee. Independent contractor. I still feel independent. Um, as opposed to being a W-2 employee. They don't have any restrictions on me. You're not allowed to work at other places. You know, you're not, it's just, so for me, that's the place where I'm happy that I've settled with my practice model. And now I'm ready to grow. And then another buddy of mine works ER at the other county, another direction, and then they lost their surgeon, and he called me up and he said, "Hey, could you come do some general surgery down here?" And I said, "I've got the perfect model." So now I have 3 places where I have contracts with my business to come in on like a per diem type of a thing that now is scalable. And I still have my job in the background, and I've cut down my hours a little bit there. But I really want them to succeed as well. And now I'm actually looking to hire another surgeon. And that's my next big critical move. So I don't know who's all going to be listening to this podcast or whatever, but um, I'm happy to share my contact info. And now you guys know where I'm at in the world and what I'm doing. And if you want to talk ever about coming to this location, or if you know of other people, like right now, what I think would be great is if I had a retiring surgeon who wanted to work 10 days a month, who could come and fill in gaps and things like that. That would be awesome. But I'm basically looking for a surgeon, and now I have a sustainable way to do it. But I went through a lot of pain and growth to get to this point. And now I'm at a point where thinking about volume and staying busy and staying confident is not even, I mean, it's not even a thought, because I've got way more work than I could, want to do.
Yeah. Yeah, definitely. Sounds like a lot of trials and tribulations that you went through, but I think you're in the right place now, right?
Yeah.
Yeah. Yeah, it was with the private practice model, with the also the handling your own billing and marketing and like budgeting staff salaries and everything like that. It also translates to less time with direct patient care as well, right? So that's also kind of a downside to private practice.
The positive side to it is that you control your schedule, you control how things are going with your, like how you communicate with your patients, and but at but but the downside is that you do all that too. Because then when do you have time to script the phone answering system with your medical assistant, right?
Yeah.
Like when you're trying to have a busy practice, and you need to be busy or else you won't be able to keep the lights on. And at the same time, the problem is reimbursement is actually going down. So like 20 years ago, since I started that, 3 years, every single year I get paid less for everything that I do. So the gallbladder paid this amount by Medicare. 3 years ago, it paid a little bit less. The next year, paid a little bit less the year after, and it pays a little bit less now. Now that will kind of go up and down from what I understand talking to older surgeons, but generally goes down. And my anticipation is 20 years from now, government payer is going to pay less, potentially, and definitely inflation adjusted is going to pay a lot less than what they're paying now. So 20 years ago, they paid more for a gallbladder than they do now, but yet your medical assistant would work for $8.25 an hour. And now the medical assistant won't get out of bed for less than $16 an hour, and all your overhead's up, and your reimbursement is literally less. Now, how is that viable? That is because the Affordable Care Act is trying to push vertical integration and trying to make doctors employed. The solution to that is doctors become independent contractors so that you can retain some of your autonomy and you you don't directly answer to a administrator suit who has no clinical experience, and you can kind of have a little bit of a buffer and a space. There's a guy named Todd Stilson who is a family med doc that if you guys get to this point where you're thinking, how am I going to set up my practice model? He describes a model that's called PC Light. So he says professional corporation, set up a professional corporation, a practice without walls, and basically describes what I backed into. But I started with the brick and mortar and then slowly shed the brick and mortar off to where that I'm not a PC, I'm actually an LLC, but for tax purposes filing as an S corp. But my business is more of like, it doesn't matter. Either way, it would be effectively the same. You get the benefit of being able to take deductions. It's much better from a tax perspective. And he goes into all of this. But more importantly than anything else, it's that mind space, that autonomy that now I can have contracts with 3 different hospitals because I'm not employed by them. And then I can go and do locums too. And nobody can really say anything. I mean, I have to live up to my side of my contracts, but the contracts don't include exclusivity things like they would if you were a W-2 employee. And there's a lot of good mental space behind that. So yeah, just go into it eyes wide open. I had plenty of money to do, and I gave myself options by saving a lot and signing a contract early, paying my loans off. I was very frugal when I was in residency. And all of that led to me having the option to be able to try that private practice, which a lot of people I don't even think really would be able to do that. But that being said, I kind of wish I would have cut my losses earlier, but you froze again because now we have a thunderstorm here, but not sure
Yeah,
if I lost you.
just for a little bit. It's okay now.
Yeah.
Okay, so how's your work-life balance? How are you managing that? I know it's a pretty delicate balance. I think many of us have families are planning having one in the future. So with a family of your own, how did you manage work-life balance in your residency, and how does it compare to your current situation? It seems like it's a little better now.
Yeah. Well, the thing about rural practice is that you have a lot of call potentially,
Mhm.
but when you're on call, it's first off, you wouldn't even think about staying in the hospital. So you don't have to do like in-house call
Yeah.
ever. And you're going to be like, I don't have an ICU at any of my places that I'm at. And so if a patient is certain level of sickness, then they need to go somewhere else anyway.
Mhm.
And so you're doing your call responsibilities then um they don't kill you because you just come in and do the easy cases basically. That's what call amounts to. And then you have control, a little bit of control over your practice. And I have little kids, 7 and 5 now, and my wife, and her love language is quality time. And um, so the most important thing that I would say that gives you that freedom, time freedom is um, this is going to sound weird, but is frugality, spending. Because if you don't spend any money, then you don't need to work for money. And then you don't, then there you go. There's your time back.
Hmm.
And so most people, their house broke. A lot of people are house broke. They bought too big of a house, and that house determines so many other expenses in their life. So it's their not just their house payment, but it's your taxes on the house, your heating and cooling bill for the house, your insurance for the house, and then the furniture that has to sit in the house to match it, and the cars that have to sit in the driveway to match it, and the kids have to go to the private school because your neighbors do, and you have to do all of these other things because of the house. Your standard of living has to match the house. Don't do that. Just get a trailer, pay cash for it, 20 grand, and be happy and have all the time in the world that you want, and then design your practice around it. And what do you like to do? Like, I don't really like doing colonoscopies, but that's my number one thing right now. So I hired a doctor who's in my practice now doing colonoscopies, and she just started. And a year from now, I will not give up my privileges to do the scopes, right? But I'm not going to be doing those on a day-to-day basis. And now I get all that flexibility from starting from my frugality. All the options that I have started from there. And then, but the thing is, it's hard to know what the right thing is to do, because sometimes I'll be at work and I'm not even pulling that big of a day. I work 8 or 9 hours, okay, on a day. But especially if I'm doing colonoscopies. And I'm like, man, my son is 5 years old and he goes to school 2 days a week and he's out of school today. And I'm here doing these stupid butt scopes. And and I shouldn't be, I should be home with him. Well, then I go home and I'm with my kids for like 30 minutes and I'm like, all right, I got to do something else. So the main thing is just consistency. Like, I'm home every night, pretty much every night, you know, getting those touches. It doesn't have to be, you don't have to be with your kid 8 hours a day for you to be heavily influential and a big part of their life, and I think it's a good example to show them a meaningful job and meaningful work that you can do. And on the weekends, I love taking my kids and rounding with me. Um, they're just kind of like in my life and we're doing it all together. I can't bring them into the OR, and really they're not big enough to sit there while I do clinic and stuff. But the weekend rounds, when I only have a patient or two to see, that's perfect opportunity for them to kind of come see what it's all about. Um, and if you don't need the money, then that makes it a lot easier, where you're feeling it in your gut. And if it's getting to be too much, then you can just back off
Hmm.
of the work.
Yeah, frugality is definitely a good life lesson.
Yeah.
Okay. Yeah, so just lastly, to be mindful of time, do you have any other advice for medical students interested in surgery to navigate their career paths? Any insights you wish you had before becoming a resident and attending?
Um, what I wish I knew, a couple things I wish I knew. Um, when I went into my third year rotations for surgery, or fourth year, um, I have one great, terrible story. So I was doing trauma rotation. This my first surgery rotation. Ah, did I lose you?
Just for
There, you're
a
back.
couple seconds, yeah, I'm back.
All right. So my first general surgery rotation as a third year medical student. And at this time, I was interested in doing surgery. So it's like really important. I was staying late. I was showing up early, doing the numbers, all the things, the work um, that I thought I was supposed to do to be like a good student and everything. And the golden boy, the best resident that they had, really liked me. Actually, he was on the rotation with me. I was having a really good time with him. I stayed late one night for a guy who had a perforated stomach ulcer, 7 centimeter humongous perforation in the fundus. It was kind of weird. And it's 7 o'clock at night, and we're going to surgery, and it's me and that chief resident who's like excellent surgeon and one of the younger attendings. And I'm living it up. And the attending says to me, says, "What's your name?" And I'm like, "Randy." He's like, "You ever heard of a Nissen fundoplication?" And I was like, and I hadn't heard of it at that point. And I said no. And then I just remember the look of disappointment of the chief resident spinning around and kind of like looking at me like, oh, making me look bad. And the chief or the attending said, "Oh, okay, well anyway, this is a Goodman fundo perforation." And he was just trying to make a joke.
Yeah.
Right? And I wasn't even able to participate in the joke because I didn't have a baseline level of knowledge that I needed to have for that situation. And so when you're going into the piece of advice is when you're going into your third year surgery rotation, what I wish I would have done is case files. I liked case files. So if I would have gotten the surgery case files book or some other book like that, that's like a review for your shelf, and read through the whole thing like in one night, but that means you can't read all the words, okay? Just read the table of contents and then go through each one and read the bold words. Like the top maybe 100 words from each chapter, and there's 40 chapters, so you read 4,000 words or something, That will allow you to at least get a framework where all the stuff that you're doing and learning kind of goes, and you can plug it away, right? Because otherwise you'll have these huge gaps. You might know like very fine detail because you did your OBGYN residency and they told you that if there's greater than 2 centimeters of subcutaneous fat, then we have a lower wound infection if we close this with a 3.0 Vicryl and we close the fatty layer. But if it's less than 2 centimeters of subcutaneous fat, then we can just close fascia and close skin. It's like a pointless, stupid trivia fact. Yes, it's true, but what you need to know is what are the causes of pre and postmenopausal bleeding. Like you need to know like the big things, the big things that make a difference and where they all go. And so that when you at least, and then the other thing is if you read before you go to each case, make sure that you're reading about the case, because I'll give you another example. Then a year later, I'm on a 4th-year AI at St. Vincent, and we're doing a Theo. And was it Theo? I can't remember if it was a Theo. Anyway, one of these cases, basically, you get to a point where you ask smarter questions. No, I know what it was. We were doing a Whipple. That was the Whipple we were doing. I only did one Theo and one Whipple on that rotation, so they stick out to me. But we're doing a Whipple, and he's mobilizing the duodenum. And I asked him, I said, "So is this called the Coker maneuver?" I asked my staff. And then they just got this big, you see the smile in their eyes. And yes, it is. And then goes on to tell me details about the anatomy that I'm looking at because I asked a smart question. That no, I would not have known that had I not read and prepared for the case. And it became obvious, And so now I become that kind of next level resident. And then they give me just a little bit more grace and a little bit more teaching. And so that would be my main advice. Blast through the bold words in a single review textbook, not a textbook, but like a review textbook before you start your maybe each one of your clinical rotations. And then keep reading as much as you possibly can. And yes, you have to show up and you got to get the numbers and you got to stay late and you have to do all the surgery that you can, but make sure that you're getting that base clinical knowledge that you can also build off of at the same time, because that will serve you well. And then the other thing is clinic. Clinic is an art. And so it sucks. Everybody hates clinic, but do some of it. And when you're doing your clinic, don't focus on just offloading work from other people. Like you go in and you think that what I'm supposed to do as a good medical student or a good resident is I'm supposed to make it easy for everybody else and do all the work. Don't focus on that. Focus on learning while you're there, like about the nuance. And if you can imagine yourself being at your end job the whole way through, and if everybody in the room just dropped dead and I was the last person on earth, how would I handle this all by myself? Think about that. Don't do it by yourself. Just think about it and then confirm. It will stick a lot better in your brain if you do that. Go through that mental exercise. And then, because you'll see where you're wrong, and then it will remember. And you'll see where you're right, and you'll actually remember that better too. So those would be my advice as you're going through training. And then lastly, be authentic and find those core things that you're still going to believe in 10, 20 years from now, and is stick with them and helps you make your decisions. Be nicer than I was. I'm not sure if you can still hear me,
Yep.
but when you're going through training, don't get too burnt out and try to. There will be people like techs and nurses. I didn't experience this at La Crosse, but I did in Mayo, who they just hate you because you're a resident, and mostly you're holding up progress because you're too smart, but you don't really know the basic things about how to get things done. Just if you could just be nicer to them and then ask them for help and just take those extra 2 seconds to like smile, and you will actually get a lot more out of your team and your experience. It's just the extra couple seconds to make it enjoyable or miserable. And I did not always do the best at that. Sometimes people are actually out to get you. They actually are. But so what? Like, you're on a path where you've already got all the tickets, and just let the water go off the duck's back. Don't get yourself too frazzled, and just like carry on, stick with your friends. Make sure you got a little bit of an outlet. And don't take things too personal, even when people are meaning them personal and they're trying to get you riled up and stuff. And if there's a real problem, focus on what the real problems are. Don't get frustrated about the little things, like when the pharmacist calls you for like the 14th time about the Tylenol order. Like, just do it. Don't throw a big fit about it. The things that really matter, like when the ICU gives your patient on post-op day 0 a Lasix challenge when they just had a big, huge abdominal whack and they need 12 liters of fluid, and instead they gave 120 milligrams of Lasix. That, don't lose your cool in the moment with the nurse right there and say something that you regret that then they're going to write you up for. Instead, just keep it inside and then take it to your direct supervisor and let them fight that battle for you. You don't have to fight it as a trainee. And then once you're a staff, when you have to fight those battles, don't fight the battles one-on-one with the floor nurse or the ICU nurse or whoever. Go upstream and have a calm but very pointed and deliberate conversation with the management, because that's how you're going to actually enact change. Don't just get upset and don't take it personal. But that was another thing that I still have not perfected by any means.
Yeah.
But if you're anything like me, you're going to have problems with.
And that's good advice, even for medical students too. I noticed that if you're nice, like to your tech, your nurse, it goes a long way for them to help you out as well. It's kind of from my experience as well. That's what I've seen, even as a medical student level.
Yeah.
Okay. All right. So as we bring this episode to a close, I just want to thank Dr. Lehman again for being here. Thank you for sharing your story. Definitely a lot of trials and tribulations. And I know You have a lot going on with work and family, so I definitely appreciate taking the time to talk to me. Your passion for community definitely shows. It's nice to see how things have come full circle for you as well. And I do think it's important to bring more attention to rural communities, make students aware that rural tracks do exist and that their benefits, even if you don't end up practicing in a rural area. And you said it's okay to share your contact information with the students that are
Yeah.
listening.
Yeah, that would be fine. So, you can put my phone number and my email. That's fine. My phone number is 219-866-6703. And then the email would be rlayman@mylibertyclinic.com. If you want to follow me a little bit on Facebook, you could search for Liberty Clinic, and it's in Rensselaer, Indiana. Feel free to give me a like on there. That would be helpful to me. And then you can kind of follow along, and there's going to be some resources that you could maybe use about specific like educational tools and things like that. The other thing is, I'm not sure when this podcast is going to be released, but I am very close to releasing my own podcast, which is going to be about rural surgery, and it's going to be called The Rural American Surgeon. So you can search for that, The Rural American Surgeon. It's not available we're recording this May 21st, 2024. But it's not available right now, but maybe by the time it's released, it will be. And if you have questions, let me know. Again, I just want to say the one thing that I need help with right now is I need that excellent second surgeon. And so if it's somebody you know, or if it may end up being you, I'm in Northwest Indiana, and now you know what I'm all about. And if you have somebody that kind of matches that, feel free to send them my way.
Yeah, definitely. This podcast should be out by today, actually. So
Oh, today. Okay.
yeah,
Well,
yeah,
you'll have to find me later on. Find
yeah,
me on Facebook in the meantime.
yeah, definitely. Yeah. So to our listeners, thank you guys for tuning in. Hope you found today's conversation helpful, inspiring. I definitely did. If you guys have any more questions or ideas for future podcasts, just please feel free to reach out. Take care, and we'll see you in the next one.
Thanks, Alvin.
Thank you.